So, hi, good afternoon all. I'm Dr. Anchal Singh on the behalf of Voice of Healthcare. Welcome you all for this panel discussion, which is organized by Voice of Healthcare. Caring for the carer, a shared responsibility. So, this panel discussion will enlighten us on decoding the government drafted guidelines to improve the working condition among the nurses in healthcare establishment. And our experts will be sharing insights over the given topic. So today we have a following eminent speaker for this discussion. Firstly, I would like to introduce our first speaker of this panel discussion, Professor Dr. Roy George. He is the president from Trained Nursing Association of India. Welcome, sir, to this panel discussion. Then we will be having Dr. Swati Rane, Vice President, Clinical Nursing Research Society of India. And she's a founder and CEO of Seva Shakthi. Welcome, Dr. Swati Rane, to this panel discussion. Then we will be joining with Josephine Cyrill. She's a Chief Nursing Officer, Sir Ganga. Welcome, ma'am.
Thank you.
And we will be joining with Dr. Clive Fernandez, Group Clinical Director and CEO of Maharashtra Workheart Hospital and Consultant Joint Commission International USA. Welcome, Dr. Clive.
Good afternoon, Achal, and good afternoon to all my viewers. And thank you, Voice of Healthcare, for having us here.
Thank you so much, sir. Then we will be joining by Bobby Ramesh, Director of Nursing Continental Hospital and Principal Assessor NABH. She will be also moderating this session from here. So without a further ado, I hand over to you, Miss Bobby. Welcome all. Welcome all to this discussion. To you, Miss Bobby.
Thank you, Dr. Anchal, and I welcome all the esteemed panelists for this discussion, which is very important in the present scenario. And I'd like to welcome all the audience who are there to hear about the decoding of guidelines regarding improving the working conditions of nurses in healthcare in India. Though nurses play a very important role in the healthcare industry, they are the most underappreciated heroes in the healthcare system. Our country currently stands at 1.7 nurses per thousand population, as opposed to the WHO norms of 3 nurses per thousand, which is alarming. More and more nurses are migrating to foreign countries for better job opportunities. Though nurses work with people ranging from newborn to patients who are dying, they are called just nurses. They lack recognition, they lack empowerment. So it is very imperative that the government and private sectors look into making policies and improving the working conditions and recognition of nurses in our country so the nurses can give better patient care which will bring in better patient outcomes. So my first question will be to Dr. Roy K. George, who is the president of Trained Nurses Association of India. So, Dr. Roy, what are the areas on a day to day basis from nurses and nursing organizations from across the country will be contacting you with various concerns? So, I'd like to hear from you the areas of concerns of nursing staff working in government and private sector.
Yeah, thank you. Thank you, Dr. Bobby Ramesh, for the question. And also, I thank Voice of Healthcare for organizing this important webinar and inviting me to the eminent panelist group. Of course, when you look at as Bobby Ramesh told about underappreciated or marginalized nursing profession in India, the very important issue is that nurses generally do not have all the facilities to provide quality care to our clients. It may be in the numbers, it may be the type of equipments provided, the working conditions provided. First of all, though the statistics shows that we have 1.7 nurses per thousand population, it is a far away statistics from the reality. This 1.7 million nurses, what is 1.7 nurses proportion we say for population is considering the total number of nurses registered in this country since 1926. How many of them are alive, how many of them are working, and such a high percentage of people have gone outside the country. But we have only that statistics. Though Indian Nursing Council is preparing the statistics of live register, it is only halfway through. So even this 1.7 is inadequate, and the real numbers are really inadequate. And the number of nurses who are going out has increased drastically over the last 4 years. Like I'm heading a nursing educational institution, and if I take just a simple statistics of the last 3 years, only less than 5% of them are now in India. Those people who could not go out of the country because of other reasons are only staying back. That is the condition. So we have a severe shortage of nurses, which owes to many many factors. Of course, mainly the marginalization of nurses, because they do not get the recognition or the salary or the working conditions which they deserve to practice their profession at its best. So when you improve the working conditions, the general fallacy is that working conditions like we argue for nurses. No, it is actually the working conditions are to be improved to provide quality care to our society. A question which I usually ask the policymakers or on a bureaucratic level, you all talk about Indian nurses' contributions to the world, they are found everywhere in the world and things like that. Are our population is not eligible to receive quality care from our nurses? Though we are, it is good to say that we remain to be the second largest exporter of nurses in the world. So is it that because we don't have surplus nurses and we are actually losing nurses because of this underrating of nurses and the marginalization of profession? Of course, when we come to the working conditions, in addition to salary is a big issue. Maybe it is near satisfactory levels in the government sector, especially in central government sector and the autonomous institution. When it comes to private sector, it is largely a desperate situation. Irrespective of historic judgment of Supreme Court in 2016, nothing has changed much except in the isolated corners. When there was a discussion about this recently released guidelines for caring for the carers by the government of India, the content of this which is made public now, most of the things are already there in the Supreme Court judgment followed by the expert committee which was appointed by central government. But when we go to central government, the Ministry of Health and Family Welfare, they say we have returned to the state government, and because its health is a state subject, we are helpless. And when we go to state government, some state governments say, if this is implemented in letter and spirit, many of the private hospitals will collapse and that may affect the healthcare. So we ask whether it is at the cost of the working conditions of nurses that we are maintaining the healthcare of this country. It is not that way. When it comes to doctors or other professionals in the healthcare, it is not like that. The current statistics say that more than 60% of the health worker force is nurses. So by leaving the largest healthcare workforce unsatisfied and undercared, how we can ensure quality care to the society? The basic amenities, in addition to salary, a decent salary, we are not saying that the salary which is proportionate with the developed countries or the Western world, at least salary which is proportionate with other professions in this country, and also maybe it is a comfortable changing room, it is a comfortable dining room, facilities like crush for, because we have a young workforce for their children, then and at least some coverage of their health and insurance. Though the government guidelines says that there shall be provision for insurance, there are provisions for health checkup, there are provisions for immunization. There is no word for these are covered by the institution, whether it is a government management or private management. Actually, when this is provided, it has to be provided by the management, whether it is government or private. That is not mentioned in the guidelines. But these are the basic things. Only thing which just pre-COVID, when the Honorable Prime Minister called the meeting, one of the important things which TNAI demanded was to have the insurance cover for the people who are in the war line. Insurance was provided, but still, there was lot of difficulties in getting the actual coverage for 128 nurses who lost their life in COVID. So these facilities are to be provided as part of the package of employment of nurses or hiring of nurses, so that they will have a better deal. Of course, then other facilities like development of continuing provisions for continuing development, paid leave for higher studies. Now, these are too many. These are the concerns which makes nurses exodus from this country, and people who remain here continues to lobby for this, fight for this, and small changes are coming in here and there, but it is as a on a pan-India basis, it to occur. All these major concerns are there for at least the last 75 years of our independent India. It continues
Thank
to
you.
nag the nursing profession in this country.
So thank you, Dr. Roy, for sharing the inputs with regard to the Supreme Court judgment, and still we are struggling to implement in the center as well as in the state government. And definitely there is a need, apart from salary, to looking into the, be it a change room or resting facilities for nurses in hospitals. I am very lucky to work in a hospital where our management pays utmost importance to nurses and nursing services, because unlike many other hospitals, we have a staff lounge for our nurses to take rest in every floor. Every ward has got a staff lounge. We have very spacious change rooms. So all these facilities are there in very few hospitals in the country. But most of the hospitals do not have proper changing room in an entire hospital. They may have just one washroom for the nurses. So the organization doesn't look into as a package, as you rightly mentioned, that apart from the salary, they have to look into the insurance, they have to look into the services as well. So thank you so much. Now my next question is to a nurse leader and abroad. So what are the challenges staff nurses face which you have observed in your long career, and what staff welfare measures are in place in your present hospital to improve the staff satisfaction levels? I heard the attrition levels are very, very low in your hospitals.
So thank you, Bobby, and thank you, Bivoj, for giving
Listen
me
up,
the
listen.
opportunity to be. Hello. Thank you. So
Yes.
let me begin with my experience abroad, working abroad, what challenges we faced. See, I have an experience of around 12 years working abroad, and I worked in Saudi Arabia, a very conservative society among the Gulf countries. And when I talk about challenges over there, remuneration wasn't a problem. It is only orienting to a new place and a new team, new professionals. So adjusting to a new work setup, that was the only challenge. And then the problem is with the language barrier. Communication was a challenge. So I don't think there were many problems. Nursing was highly empowered. There was enough number of nurses, so nurse patient ratio wasn't a challenge. Attrition wasn't a big problem. Very peaceful environment. Nurses are happy, and there are a lot of training activities happening, and self development also was happening, and plenty of leaves. Annually you can come home, spend 45 days with your family. So that was a great time. Now, let me talk about the challenges we generally face during my career experience. Most of my experience had been in corporate, now in private sector. I totally agree with Dr. Roy. The number one problem, what all nurse leaders, I'm sure Bobby will agree with me, is nursing attrition. Throughout the time, the nurse leaders are thinking about how to cope up with the attrition. And attrition vary from hospital to hospital, organization to organization. And I'm sure this attrition is, all of us know that it is more with the private sector. Now, with the poor nurse attrition, what happens, or improper nurse attrition, whatever we call it, when a single nurse has more number of patients, it affects the quality of care. All of us know it. And then she or he is tired, and we are not able to give them the leaves as per the schedule. We ask them to stay extra hours. patient care is affected, they commit mistakes, and their own satisfaction goes down and patient satisfaction goes down. So there is a huge challenge with the nursing attrition and nursing dissatisfaction. Another area which I notice as a big challenge among nurses in nursing fraternity in India is the recruitment process established by the various hospitals. Nurses have left the organization, gone, and we haven't recruited and replaced their positions. So there is a huge gap between the number of nurses left and the number of nurses coming on board. So when you delay the recruitment, or when we are not able to find the right talent from the market to replace the people who are leaving, and there is a gap, you might have got good number of experienced nurses leaving the organization and you have replaced with the fresh graduates, then it becomes very difficult for the organization to cope up with the kind of care we are expecting out of them. So there has to be a kind of system where nurses are recruited well in advance, so that if at all they are working already, they can give the notice period and join us on time. And the gap between people leaving and people coming on board can be strengthened. Another challenge is inadequate or not established properly mentorship program in the organization. We have good number of nurses on board, or we do not have good number of nurses on board because of the nursing attrition. There has to be a good preceptorship program or mentorship program for the new nurses joining the organization. Because of the nurse patient ratio, the numbers are not adequate. Though on paper the preceptorship program is in place or the mentorship program is in place, we are unable to get it happen and going and measure the outcome and bring a good preceptorship program in place benefiting the young nurses. Though we are aware, we are not able to do it successfully. That's a huge challenge. And once they start taking patients after the preceptorship program, we expect them to perform, but we haven't given them the right guidance and the right time to relax and learn things in the setup. So then there are other challenges like long working hours. People fall sick, and when they work long, they are not able to get leaves. They are sick, they take medical leaves. When they take medical leaves, it affects again the nurse patient ratio on the floor and the quality of care. Nursing empowerment is a huge concern. Some places nurses are empowered to an extent, and there are institutions where nurses are not empowered at all. So there is a huge gap. Though on paper there is nursing empowerment and nursing empowerment policies are in place, we still have to strengthen nursing empowerment policy in India. Non-nursing roles are hugely performed by nurses. There are lot many roles which can be taken away from nurses, which are done by nurses. For everything they depend on nurses. It becomes very difficult for the nurse who has good number of patients, and especially she is posted in a specialized area. Her responsibilities are huge, but she is supposed to perform the non-nursing assignments as well, which becomes a huge task in front of the young nurse. And lack of career progression. People working in certain areas keep growing in the same area, same job, every day, same routine. There is nothing is shown to them by the management, by the nursing department, a career, a pathway for that person to grow and shine in her career. That's a huge challenge. And many times nurses leave the profession, or they stay very unhappy and they retire as not a very happy person at the end. Today's time, a new challenge I am coming across is flexible working hours. Many nurses, especially after this pandemic, they come and they ask for straight duties. They cannot do, 3-shift pattern, which we have in most hospitals. And many nurses have lost their husbands, their life partners. They have no help at home. There are so many single mothers. And also, I see a lot of nurses have health issues, mental health issues, physical issues, operated, treated for cancer. There are nurses with major surgeries done. They want light duties and light working hours. With the tight nurse-patient ratio on floor, it becomes very, very difficult for nursing administration. Then the remuneration is a huge challenge. People are looking for why we have so much of nursing attrition. We have done a lot of internal studies why nurses leave the organization, though number one reason is going abroad. One of the most important reasons why they leave the organization is looking for a better salary. Especially people who are coming on board, even if you have selected them, they give interviews in 5-6 institutions, and wherever they are getting little extra, they go and join there. They look for a better work environment, means better remuneration for their career satisfaction. There is no uniformity in hospital to hospital. whether it is standard operating procedures, whether it is policies and protocols, or whether it is welfare activities for nurses, there is no uniformity in our country. Each organization has their own methodology, and there is the young nurses are not aware where to report and how to get their grievances going other than within the organization. So one of the challenge in many organizations, there is no nursing welfare association in the hospitals for their own welfare, represented by them, the mid-level managers and senior nurses. That is a gap. So there are a lot of issues today facing, and another area what I noticed is professional development. We see so many big hospitals coming up, but there are good number of nurse leaders. Are we grooming them? So the mid-level nurse managers have to be groomed and trained to take up good positions in future. So now coming back to the second part of the question, in the current organization, you were asking what are the welfare activities we are doing to improve the nurses' satisfaction. First of all, we have a nurses welfare association, which is the senior person, the senior nurse leader is the chairperson, and there are around 5 to 6 good mid-level managers in the team, and they listen to the nurses, they look at their grievances, and every issue is taken care. So they feel they are very, very empowered. And also there are good number of nurses with a good experience. You are blessed if you have senior nurses working in the organization because they are not leaving the organization. So the nursing attrition is less because they are happy, because their remuneration is good, they have medical benefits, they have uniform allowance, they have festival allowance, they have more number of leaves, means at least 6 leaves in a month, along with other gazetted holidays and other leaves, because these are required for sustain their own personal life and also to keep their family members happy and the professional life going on.
Thank
Then,
you, Ms. Josephine.
thank you. And the non-nursing roles are also supported by other personals. So these are the welfare activities we do in our organization. Thank you, Bobby.
Thank you, Ms. Josephine, for sharing with us the concerns related to non-nursing activities by nurses, which has to be looked into. And we need to consider flexible working hours. Like in Western countries, nurses should be able to choose in flexible working hours, so that who are resigning because of the shift system, and if they can come for a straight duty or the shift which they can choose, many nurses will not resign, or they may not go abroad or take a break from work. And in welfare measures, definitely their offs and leaves and allowances do matter a lot. Apart from a welfare association, that's a good input. Thank you so much. Now my next question is to Dr. Clive. Dr. Clive, you're a physician and an administrator. You wear two hats. I'd like to hear from you the present scenario with regard to working conditions from that point of view, and what we can do differently.
That's a good question, because I was wondering, Dr. George and Miss Josephine have already actually summed up, if you ask anybody, kya problems hai desh mein, it will be attrition, it will be money, and I totally agree, but then I want to give it a little different perspective, and we look at it differently. Bobby, when you opened your talk, you talked about something. Your first line was nurses are the most underappreciated. Now you see, that would have summed up, and I'm touching a raw chord with everybody, and even in our nursing audience, because I am telling you yes, and that is there. So today I'll just put a different spin to all of this. I'm not going to talk about attrition, money, or any of this because it has been well taken care of. But I believe this has not changed today. This has been the way it is, and there is still a long time before any of this will change. So, in any improvement project or, quality projects that we do, we have the low hanging fruit and then the long term goals. Today, I can tell you one thing. Now, as a physician, I'm not even going to talk as a physician, but as a group medical head, I have seen, and it's not me, each of you have interacted, you work in organizations. How does a physician or a doctor actually address a nurse? How do they talk to them? How many times, you may have got people coming and saying the physician yelled at me. Money, empowerment, creases, all that you spoke about, that is all okay. But this is something a person faces day in and day out, 24/7. I know I've seen cases where, nurses actually, when they see a particular physician coming, they run away. Ki, "Arey, wo aa gaya." अभी वो चिल्लाएगा. I don't like that person. So I just want to say, I even put it on my social status, today, that we talk about nursing day and there is one big day and we celebrate it and we do all the ho halla that we have to, and then the next day everything comes back to normal. So if you talk about what is required, I'm talking about the perception of from the perspective of a physician. We talk so much about empowerment, and Miss Josephine brought it up, and she said yes. She said it's just a word. There is nothing into it, because if you talk about empowerment, tell me one thing: how many times can a nurse tell the doctor, "Sir, you have not washed your hands, or you have not performed hand hygiene, you don't touch the patient"? She can tell, provided she's got another offer in another place, because she won't be there the next day. So when we talk about empowerment, a lot of people write a lot of articles and a lot of jargon about everything, but the fact of the matter is, on the ground, there is a long way to go. So when I would just say, I would love people, not only physicians, but all healthcare providers. As a physician, I would say, walk the talk. So I would like people to walk the talk. There is no point of saying we do all this. We have these protocols, but at the end of the day, we all know what happens on the ground. We need to reset our behavioral DNA, not physicians, every healthcare provider in this country. I don't know, for some strange reason, we said corporate versus government, but believe me, there may be only jargon and appearances ka difference. The way nurses are treated, I think it's going to be the same everywhere. As an administrator, and I came to another lovely point, because I think you all brought it up on non-nursing rules. As an administrator, we need to take out that philosophy that nurses are an expendable force. Because that is what it is. Okay, if this one goes, someone else will come. Look at the average. You will, Dr. George will tell me, what is the average career of a nurse in an institution. I'm not talking about senior people. Bobby, if you talk about Bobby, she may be 10 years in a place because she's nursing head. But I'm talking about those people who come on the ground. And why is it like that? So it is just how we consider them expendables, non-nursing roles. Exactly what you're saying. And I'll just end it with, I'll give you an example. 4 years ago, I did a project in my own organizations, because my nurses were not able to spend time with the patient. So we did a time motion study. We followed them, blah, blah, blah. I found that there was 35% time that we could save of theirs by making them not do certain jobs. And it is not that those jobs are not required. Those jobs are necessary healthcare wise, but it was not necessary to be done by a nurse. And when we talk about 35% of time in an 8-hour shift, you do the maths. So very rightly said. So as physicians, as administrators, I would just, want give this message. Let's walk the talk. Let us treat nurses as equals. Somewhat, Miss Josephine, you were in Saudi. A lot of people will be in the States. You talk about nurse practitioners. In the West, physicians are actually afraid of nurses.
Nurses. They have better
They,
autonomy.
they not only autonomy, and they are afraid for the right reasons, not the wrong reason, because they know they are not doing something right, and this person is empowered to stop me, and she will stop me. Unlike here, it all depends on how big I am, and okay, you said this to me. Okay, so now so that way. So I like this topic, caring for the carer, because yes, lot has been done, but if you look at what is there, I think there's still a long way to go. But they say, the moment you begin, you can move. And conferences and webinars like this, when it highlights these issues, that is when we will be able to make a change. We spoke about salary, we spoke about everything. Come on, today I will say, I, one person, decide to change this and give people 5x the salary. What am I talking about? Because this is not an institutional. Okay, you are right. Someone said private is worse than government, but it is all relative. You are only as good as what you're compared to. So, why do people go out? I was just seeing, 10 years ago, our doctors used to go out. When I got doctors back, they said, Dr. Clive, 15, 20 years ago, we used to go out because there was nothing in this country. Today, they are all coming back. But even today, they are coming back, but our people are going. So, this is good that The government has noticed, there are notifications coming, there is work being done. But I would like to say this is just the tip on the iceberg. There's still a long way to go, but I am happy that we have begun. And I would only want to give my audience one message. If you are anyone apart from a nurse, if you're anyone apart from a nurse, you should start treating a nurse the way they want to be treated, not the way you treat them. Treat them as an equal. Thank you.
Thank you, Dr. Clive. I liked your mentioning nurses to be treated as equals. And regarding the nurse checking on a doctor for hand washing, I should share here in one of my previous hospitals, one of my ICN said to a doctor, Doctor, you are doing a procedure without doing a hand wash. You cannot do this procedure. And the doctor shouted at my ICN stating that, how dare you tell me I'm a doctor and you dare not talk to me like that. And the ICN came crying to me. I took him to my medical director and I said that the doctor cannot be talking like that because my infection control nurse is empowered to check anybody who's not performing the hand hygiene. The medical director called the doctor and made him apologize to my ICN. But it happens
So
only in
we
very
need so we need 1.7 bobbies per thousand population, because the problem is bigger.
So as you
True,
rightly
true.
said, nurses must be empowered and everyone should be, the other healthcare member, the doctors and the administrators should be treating nurses as part of their health team, and they should not be considered a expendable force. My next question is to Dr. Swati. Dr. Swati, you have done your PhD from a reputed institute, Tata Institute of TIS, Social Sciences, with an interesting thesis topic: influence of physical work environment on the nursing work practice and outcomes in public sector. Though you have moved away from nursing and you have done a MBA in hospital admin and a PhD you have done in nursing work practice and the physical and work environment. Why did you do that and what were the observations of your study? Could you please share with us?
Thank you, Bobby. I thank Voice of Healthcare for giving me this opportunity, and I thank my panelists and the audience for giving me this opportunity to bring my thoughts here. Basically, this topic came up when I was working with workhards in the project departments as a hospital planner, and I realized that most of my space is nursing space, but it was never called as nursing space. It was called as inpatient wards. Okay. And when we started planning, started asking them, why don't you ask nurses what they want? Because 24/7, it is the whole hospital is manned by them, not manned, but actually taken care by the nurses. So why don't we take a review from them? And they said that no, you for making a automobile, do you go to the driver? I said yes, because he is going to sit there, and that was my perception of as a planner that I have to be user friendly. Okay, and we did some work with the users, and we understood that what their needs were, and we planned the Vocard second phase, which is there in Mulund now, which is a Fortis thing, as per the user's needs. And that time I realized that hardly any work is done in these spaces because the users are not at all coming into picture in the planning process. And that's how this nursing topic came up. And physical work environment was never thought by nurses, because they directly come when the physical structure is done, but so much of wastage of money, time, space is there because the nurses are not there. And I came across a new budding group which is called as Nursing Institute of Healthcare Design, where only nurses are there who are teaching the architects and the medical people how to plan hospitals. And that's how the study started. And by the time I thought of doing my PhD in this, already I came back into nursing at a different role as a facilitator to bring nursing issues to the top management and to the government, and also to the private sector leaders who hardly thought that nurses can be visible anywhere in the decision making process. So what I realized was that nursing is invisible, completely invisible. There is no visibility for nurses, nor in their work and nor in their decision making. And that is the reason is because they are as cost centers. Okay, they are not as revenue centers. So it is basically the physician model is more of revenue centered. Okay, that is the reason you can see physicians growing, but the nurses who are at least taking 80% of the load of the physician and the patient, because it is she's under the cost center, she's her all the work is there in the payment of the bills under the heads of what the the cost of the bed, the cost of the room. Okay, but not
The
as the
studies was done in, excuse me, I would like to interfere here. I would want to know, so where did you do the study in public
yeah.
sector and what were the
So
observations?
yes, so this study was done in the public health sector. My experience was in the private sector. So I thought of taking up the public health sector because I wanted to understand the organogram, because all the policy making decisions are done at the state level. And at the state level, if you see the organogram, there is hardly a nurse there in the decision making bodies. So all the joint directors are the doctors, they are physicians, there is no nurse. And at the ADH level, there is a nurse, but that is the level where it stops. But she is not having any backing for taking any decisions. So even in the planning phase, the nurses are not involved because the ADH nursing is taking care of all the nurses. And if you see at the center level, there is one nurse advisor. And we think that one nurse advisor will take care of 35 lakh of nurses, which is not possible. So structurally, I think there is so much of invisibility of the nurses. So from where the autonomy will come to the nurses if she's not there in the structure? So I feel that in the structure, you have to bring nurses like Bobby, Josephine at the top level in the government, at the parliament, where the policy making is happening and where the voice of the nurse is to be heard. If you even see the working conditions which are drafted, who has drafted this working conditions? Was TNAI involved? Was private sector involved? Was public sector involved? Who has done it? We don't know anything about it. So from where, from whose hat has it come? Who is responsible? Which is the committee? If it is a government draft, where is the committee? So without all these things, and this is only because structurally nurses don't exist in the structure of the government nor in the private sector. And 80% healthcare is private sector. So 80% of the nurses you're going to find in the private sector. So where is their voice? Are the private sector nurses involved in the government decision body? No. So who are we trying to fool around with by bringing in these working conditions? I'm sorry, but they are fooling us, and I don't appreciate this at all.
Thank you, Dr. Swati, for your inputs on on your observations related to your study that nurses are not yet visible. And Dr. Swati had lot of queries and questions related to the recent draft guidelines released by the Ministry of Health and Family Welfare. So I'd like to request Dr. Roy to share your observations and suggestions on the recent draft guidelines. Over to you, Dr. Roy.
Yeah, the recent guidelines and drafts were result of continuing representations at the ministry level regarding the working conditions and salary, and then the COVID also has helped us, and also there was many letters from the international bodies like World Health Organization and ICN, and this all resulted in bringing out these guidelines. But like as Rane told, there is definitely a lot of inadequacies in this program because it is not directly formed after consultation with nurses, either at government level or the private level, private sector, government sector and private sector. It was just formed by the ministry by an internal committee. And when it was formed, there was only one nursing person at the all Ministry of Health and Family Welfare, New Delhi. And the nursing advisor post was vacant. It was just filled 2 weeks back. So there was not much concern. But these are things which everybody knows. But interestingly, there is no mention about salary or the career progression. No mention. See, just the working conditions. What they have taken is the secondary things, which is like just facelift or things like that. But directly, first of all, whenever the professional thing is taken, they have to address, because 80% of the people work in the private sector, and everybody knows that private sector salaries are so desperate. There's no mention. And secondly, not about career promotion, and that even in the government sector, in central government or state government, there are people who join us at the basic level and retire at the basic level itself after 25 years or 30 years of service. So if this career progression is not ensured, how? Then also, what are the some offers, some things which are mentioned also is not complete. Like they talk about insurance, they talk about immunization, they talk about coverage for score life, but nothing mentioned whether it has to be provided by the institution, that is government management or private management. Say to tell about insurance itself, but if the nurse has to pay it from the her salary, then what is the point of that? She can take even without the hospital support. At least there is no clear guidelines firstly on the positive points, even in the positive points which they have mentioned. Then they had told about mechanisms of addressing the grievances. But when it, like recently in one of the Delhi central government hospital, there was a big issue, and we were involved. TNAI was involved when our officials went there. The person who is chairperson of the grievance committee is the person who has caused this sexual abuse. So that is the situation where there is no structure told, nothing is told, nothing is specifically told. Though there are guidelines by the ministry, it is not specifically mentioned how it is formed. Then there is no mention about ensuring the nurse-patient ratio and facilities for quality care. And another area where we have a big problem is that we have many specialized nurses working in the service side, especially in the government service side, but they are not usually posted to their area of specialization. The qualification for the basic post of a nursing officer in central government now is BSc nursing, but MSc nurses are joining in large numbers there in clinical side, but almost always they'll be posted in some area where they have no specialization, though they have a specialization. So there is no mention about career development also, this mention is not made. And the staff inspection unit norms, which is formed many decades ago, is still followed in some government hospitals. There also the vacancies are not filled, but still there is no mention about improving the the nurse-patient ratio, because the requirements of nursing care with advances in medical or healthcare has increased a lot. There is no mention about how to improve nurse-patient ratios. And as already discussed by Madam Josephine and all, there is non-nursing jobs, and there is no clear job description as such. There is no mention about the job description is something which is very basic. In the last 5 years, there are a lot of some controversies about the postgraduate medical students and nurses fighting each other who will draw the blood for lab administration. So there is actually no clear job description, and most of things which are available are outdated. And of course, staff development programs, the nursing development programs, continuous nursing development programs, like many specialty sections are formed even in the government hospitals, and there is no proper in-service education is given to nurses posted there. Many times no induction training also, and that then they will be finding it difficult to adjust, and whatever they do will be blamed, or the doctor yells at them because they have not been informed about what is to be done, because a super specialist comes from somewhere else and that's the thing, and nurses are not equipped well to meet the demands of care there. And there is no mention about, as I already told, as there is no mention about the number of vacancies or the nurse-patient ratio, there is no mention about the supervisory care or management level. And at a time, when the COVID was in its full rate, almost all the central government hospitals, except All India Institute of Medical Science, Delhi, all the central government hospitals in Delhi, none of them had a head of nursing. All in charges were there. That was the situation in this country. So no importance is given to that. And there is no uniform recruitment rules and no recruitment pattern. It is changing from time to time. And there is a lot of efforts to employ contract nurses or outsourced nurses in the government sector, which again is going to cause higher exodus of nurses from this country, because irrespective of all the negative things, still a government job remains to be attractive for the nurses. And when the appointments are not made, the permanent appointments or regular appointments are made, they are not going to be here. And policies for at least higher education of nurses. So all the institutes give, no other institute gives higher education leave usually. There is no mention about such development. And risk allowances for nurses who are working in high risk areas, and also another suggestion which TNAI has made, some standardization of uniform in both in the private and government sector. We have certain uniforms in government sector which is quite outdated and quite not suitable for our working conditions as well as the climatic conditions, and some things are quite there's no uniform pattern. That is another thing which we have mentioned in our note to the government of India on these guidelines. Overall, this initiative is good, but how far it is going to help and how it will inculcate the suggestions which we are given by nursing organizations or professionals or professional leaders is something of area of concern, and definitely there are a lot of suggestions which are come. Luckily, at least now we have the nursing advisor person is in place, and the new Assistant Director General of Nursing is going. So we hope that there will be some change, at least a beginning of a change with these new guidelines. That's our hope. Thank you.
Thank you, Dr. Roy, for sharing with us the lacunae in the draft guidelines regarding the salary, the insurance, the nurse-patient ratio, and the place of posting for nurses with area of specialization, and also the JD and the staff development program. And I hope government authorities look into this before the final guidelines are released. My next question is to Dr. Swati. Dr. Swati, you are a social activist too. So, what are your suggestions on empowering nurses and their recognition?
Uh, with the social activist hat which I had to wear during COVID times, I realized that most of the private hospitals had to shut down during COVID because a lot of issues of nursing were there and the patient care were also there. And that time I really realized the importance of the role of unions and social welfare associations, which are very, very much needed in private sector and public sector both. Without unions, I don't think the nurses can bring their voice on the table of the management. And unfortunately, union was used as a bad word for a long time in this country, but I feel union is a great word. Internationally, we have nursing unions which are doing all the negotiations with the government and with the private sector management. So we need to have best unions, and for that we have to bring in the advocacy movement. Okay, and the nurses should start coming out with voices, especially the leaders have to come out with their voices, and they have to stand for it, because unfortunately today, if you see the private sector, there are majorly the leaders, their salaries are so high compared to the nurse who is there with at the bedside. Okay, I think the disparity between the nurse's salary at the bedside and in the management would be around 16 times. Okay, so I think there we have to start working in. We have to bring the best leaders, okay, who can bring the voice of the patient and of the nurse to the management. Okay, and see, nursing is not a profession which is only for medical or a clinical reason. It is a social profession. Okay, so today the nurses have to understand that it is not their responsibility only stand for the patients, but they have to stand for themselves first. When the nurse is working in a good working condition, only then she can give a good care to the patient. Just imagine a nurse, you see the public healthcare nurses, hardly anything is mentioned about the working conditions of the public healthcare nurse who is working in the community in this draft. Where is the job chart? How difficultly they, I mean, look at the ANMs who give the doses. You see in Assam how much they travel. They swim and they go to give the doses. Okay, so
Vaccinations.
where is it mentioned in the working conditions draft about them? Where is the safety and security? Look at the abuses nurses face. Dr. Clive very well said that, you know, the amount of the abuse the nurses faces on ground, and these are just 24-year-old girls. Okay, so you have to make them empowered, and that empowerment comes from the nursing schools, the nursing colleges. You have to bring in gender bias training, sensitize them about the issues they will face at the ground level with the patients and also with their colleagues. Okay, so maximum of the gender bias training is not taught in the nurses. Recently we had a sociology book issue where they said that, you know, I should not say this on the national television, but I would not want these type of sociology taught to the nurses. Now we have to teach the nurses about the gender issues which they have to fight for, as and nursing is still a female dominated profession. And thirdly, I want to say is that Bring in the management to talk at the ground level with the nurses. Have one-to-one talk. Bring the grievances with the ground level. Just remove the nursing leaders for some time when the grievances are dealt with. Let the HR take the interest in the nurses. Let the management take the interest in the nurses and understand their issues. Okay, and in the public health hospitals, still they are struggling for good quality water. Changing rooms are not there, ceilings are falling on their heads, and the injury is being taken care by the private health sector with the with the nurses insurance. So what are we talking about? Where is nursing? Invisible, completely invisible. So visibility will only come when the nurses are empowered in their schools. Empower the girls and the boys in the nursing schools. Only then they can fight out in the actual real conditions where they are going
Thank
to
you,
work in.
Dr. Swati.
Thank you so much.
Thank you, Dr. Swati, that they need to be empowered, they need to be taught in the schools and colleges when they are studying so that they'll be more confident to face in the organization when they face any bullying. Thank you so much. My next question is to Ms. Josephine. Ms. Josephine, Dr. Roy has already shared about many lacunae in the draft guidelines. As a nurse leader, what are your observations and suggestions on the draft guidelines? Over to you, Ms. Josephine.
Yeah. See, Dr. Roy has almost, he has covered most of the points. And I really liked what Dr. Swati said. Who drafted all these guidelines? How come the inputs are not taken from the nurse leaders? Quite strange. And I really like what Dr. Uh, I forgot, Dr. Clive.
Clive, Dr. Clive.
Walk the talk, walk the talk. Very nice, walk the talk. Equal platform for doctors and nurses together interacting each other and learning from each other. So we have reviewed these guidelines thoroughly. In fact, I had the opportunity to review the whole thing with our nursing core team. And one statement which I have, most of the sentences it is written as far as possible, inverted comma. Why not change that as far as possible into shall be? There shall be. I think shall be makes more meaningful and more powerful shall be, but that is my suggestion.
As
And it
far
is
as
not only my
possible,
suggestion.
maybe. Maybe, may not be.
But that doesn't work. We are thinking
Absolutely.
about making things happen for the nurses, and then I think that change should happen. Now, point by point, I'll just brief up because many things Dr. Roy has already told.
So no
Now,
repetitions, please,
no,
because we are
no
lacking
repetition I
time.
want to do. Nurse-patient ratio, we have INC guidelines, NMC guidelines, other guidelines, so we should follow that strictly. Recruitment process also should be based on the NP guidelines, in nurse-patient ratio guidelines. Now, crush facilities. There are many young nurses in our country who are lactating mothers, pregnant women. They have issues with their kids. Very routinely I see that they are facing issues with stabilizing their family. I think crush facility is hardly provided in many organizations. It should be available 24 hours so that nurses can perform all the shift duties and they are quite confident that their kids are taken care of. And all the benefits what all of us spoke and what is written in the draft, it should be irrespective of you are a contractual employee, you are a private sector, in a public sector, anywhere. I have seen during my journey, traveling from north to south for various reasons, that there was a hospital recently I saw there are just 2 offs given in a month. For any extra off taken, that will be considered as leave without pay, which is very, very strange. Nurses should get enough number of offs. So I think that has to be specified, whether it is 5 days working, 40 hours, whatever they have written, how the offs have to be managed, how the 30% or 20%, unless we have 30% replacement, it is very hard to maintain the number of offs the nurses are supposed to get, which is not clear in the guidelines. And many senior nurses have raised concern there should be some kind of pension for the nurses who have worked in the organization for many, many years, not leaving the organization, staying with the organization, being very loyal to the institute. And they have given their youth, their all commitment, their energy, everything. So I think a kind of support system should be there. Then flexible working hours is not mentioned in the draft guidelines. One major issue which nurses face, which we may think it is not very important, is nurses should have separate washroom, toilet, very adjacent to the nursing workstation. And the workstation should have enough space. It should be designed with the consent of the nurse leaders and mid-level nurse managers. Enough space for biomedical equipment, enough space for storage, enough space for nurses' lounge to heat their food, a place where they can take their break, long hours if you are in a cath lab or OT where they will rest. And toilet facilities should be, there should be male and female separate facilities adjacent to their workstation, so that in the night they don't have to walk long away. Lot many things have to be looked into. And paternity leave, we only talk about mothers. What about paternity leave? At least for a few days, we can think about it. It's not mentioned in the guidelines. What about transportation? Nurses travel from far off places. If they have a stable job, they don't want to lose the job. And so we have to look into transportation and to safe transportation. Then welfare thing I already mentioned, mental and physical violence. If at all there is a violence by the patient, by somebody in the healthcare system, are we looking into, can they confidently escalate that concern and get it resolved? Good counseling for them, those who are seeking mental guidance, mental kind of a support. And then nurses with the kids needing care. There are nurses with kids serious medical issues that prevents them from concentrating on the job. They may be performing very well. They are excellent nurses, but their kids are sick. What we can do for them? Some kind of a thought has to be put into. Then pregnant woman in the last trimester working in specialized area, can she have a lighter area posting? Can she have less number of nights or no nights at all? What is that kind of a system for considering their physical condition? Then rotation of nurses. Rotation of nurses, as Sir rightly said, many times we put nurses as per our requirement. But are they happy? If I'm not happy working with kids and you are forcefully putting me in a pediatric unit, I will not deliver my best. So if you have enough number of nurses, only we can post them in the relevant areas so that they can learn, they can enjoy their work experience. And after working few years in a particular area, when they ask for change, organizations have to think about special guidance, training, mentorship program, and then posting them to the specialty area wherever they are supposed to be assigned, with a good risk allowance of that area, specialty allowance we call it. So a good mentorship or preceptorship program make it more powerful. So these are some of the suggestions I have which can be improved upon when I review the draft, the guidelines.
So thank you so much, Ms. Josephine, for bringing in this creche facilities thing, because in our hospital too, we started with the creche facility, after which we see the leaves taken by the nurse managers and nurses reducing because suddenly the maid didn't come. Creche facility, the offs, considering for pension for senior nurses who are in the system for a long time, and flexible working hours, apart from washrooms for male and female staff, and the nurses lounge, which is mandate for the staff in every working area. And the counseling post covid, everybody requires counseling. Most of us are in stress, and like any other healthcare worker, nurses too require assistance in counseling, so such facilities should be provided. So thank you for the inputs. My last question is to Dr. Clive. I would request, because of lack of time, I'd request Dr. Clive to share your observations as an administrator on the draft guidelines, and the role of corporate hospitals in improving working conditions and reducing the attrition of nurses.
I'd like to sum it up. If you're asking me the role of corporate hospitals, we have no role. पूछिए क्यों? Because how many nurses work in corporate hospitals? This is not a session on caring for the carer in corporate hospitals. Corporate hospitals, you might be having hardly 5% nurses. We are talking about nurses across the spectrum. Dr. Swati, Ms. Josephine, you will all agree with me. And I'll just throw the cat among the pigeons again. Most of the things that you said you want to see happening is happening in bits and pieces in only corporate hospitals. आपने खुद बोला, you got a creche in your hospital. There are lounges in your hospital. There are some things in somewhere, but the problem is not of keeping one thing in one place. We want every nurse to have this facility, irrespective whether they are in government or in private. So I will say, like, corporate hospitals can take the lead. Like when accreditation came 15 years ago, it was only private and corporate hospitals, but then look at the government of Gujarat. Then the government hospitals went in. So corporate hospitals can take the lead, but everyone has to work on this. And now I come to the big point, the best point. everybody talked about, guidelines. आप बोल रहे हो nurse patient. 1:5, what is it in government hospitals? What is it in corporate hospitals? What you told me are guidelines. Guidelines are for reference, they are not mandatory. अगर लाल बत्ती पे रुकना है तो लाल बत्ती पे रुकना है. You cannot tell people कि red light you stop, it's a reference, you stop or you don't stop. Now when I look at the guidelines, everyone has already spoken on it. I'll just give a 50,000 feet what I looked at and found very strange. Adequate infrastructure and well-equipped workstations. So it talks about adequate number of qualified, trained, competent in every ward. Each word of this is so subjective. What does adequate mean? Does adequate for a corporate hospital, is it the same as adequate for a OPD or a clinic? What do you mean by qualified? So what do you mean by well-equipped nurse station? Now when you leave it to every person to have their own individual thing, well-equipped, ठीक है साहब, एक टेबल लगा दिया, एक कुर्सी लगा दिया, that is well-equipped. And दूसरी जगह आप कह रहे हो मैंने क्रीच लगाया, मैंने लाउंज लगाया, and someone will pull the rug off from your that कि आपने पीने का पानी नहीं लगाया. So till these guidelines are not objectively defined, because our objective is not corporate or a particular hospital. Our objective is to improve this consistently, make the life of a nurse across the spectrum, be it corporate or be it government, make their life better. And I'll give you an example. 15 years ago, I was really surprised. Now we come to the last. I'm just going to sum it up with this. The nurse in the ICU in a hospital where I was working 16, 17 years ago, she earned less money than the chokidar on the building, security of my house. And I was actually thinking, in the hospital, we are trusting our loved ones with their care क्योंकि आप ICU में जा नहीं सकते हो. So there is really something wrong in the way the remuneration structure has been built in society in this country. It is not about corporate or government. It is that that inherent, so we have to look at it in that sense. So that is what I would like to say. And it's not corporates are doing their bit, let me tell you, but we want it to happen consistently for every person.
I'm so sorry. I only mentioned about the reducing the attrition, what we all can do, because we are facing
Correct.
day in and day out alarming,
No, fair,
attrition
fair, fair.
rates.
So that's what I'm saying. But what we have to do we are already doing our bit. But we are already doing our bit. But when these guidelines are made more objective, it will help to get consistency. And everyone will then be able to at least define the common things. That way.
So thank you, Dr. Clive, for bringing out the subjectivity in the guidelines. The guidelines have to be more objective, as
Objective.
mentioned by you, so that every organization can follow that objectively. So it was a very interesting and a very informative session, wherein Dr. Roy mentioned about all the lacunae, brought about the lacunae in the guidelines, and Dr. Swati mentioned about the nurses being not invisible, and they need to be more empowered and make them more visible. And she had concerns on why the nurses are the various nursing organizations are not part of the committee which has drafted the guidelines. And Dr. Clive mentioned about nurses have to be considered as equals by the doctors or administrators, and they should be treated with respect. And also there has to be objectivity in the guidelines. And Miss Josephine, with her vast experience, she brought out various aspects of these guidelines related to the working hours, related to the JD, related to the staff development program, related to the preceptorship, and also related to the flexible working hours and ops. So thank you all so very much. It is definitely very important for the government authorities to look into all these inputs and the guideline inputs while finalizing the guidelines. More nursing representatives, both from the public as well as from the private sector, need to be involved in the decision making or involved in the inputs of finalizing the finalizing the guidelines. Now, after listening to Dr. Clive, I feel that even administrators and doctors from both the public and private sectors have to be from the especially the private sectors also have to be involved or included in the committees. And only then the guidelines which will be released, the final one, will be more effective to be uniformly implemented across the country, and we look forward to the final guidelines, the final draft, which the state governments and the central government should be looking into for implementing, so that our nurses do not go in large numbers to foreign countries. That they should not come where we have all doctors and other healthcare workers in our country, and we do not have nurses to take care of the patients. So a safe and healthy work environment is imperative in order to provide quality care and better patient outcomes, for which nurses have to be looked after, their working conditions have to be improved, they have to be empowered, they have to be recognized, and they have to be rewarded. With this, we come to the end of the session. I'd like to thank the esteemed panelists for taking out their time from their busy schedules and contributing to a very, very informative and an effective discussion. And I'd like to thank Voice of Healthcare, Pinky, and Dr. Anchal Singh for
Thank you
organizing
so much.
this webinar at a very short notice, which is a need of the hour. And I'd like to thank all the audience for joining in for this webinar. Thank you all so much, and namaste.
Thank you all for this
Thank
amazing
you.
session.
Thank
Thank you, Dr. Roy. Thank you, Dr. Clive. Thank you,
Thank
Dr.
you.
Swati Rane. Thank you, Josephine. And thank you, Bobby Ramesh. With this, I would like to bring the end to this session. Thank you, everyone.